Many objectives are here, of course, this will be covered on exam 3. So we'll start with thyroid. Thyroid, as you know, is part of the hypothalamic pituitary thyroid axis. So you have at the top level, thyrotropin releasing hormone that regulates pituitary secretion of thyrotropin, which then acts on the thyroid to secrete thyroid hormone itself. TSH or thyrotropin is secreted on a circadian rhythm, on a pulsatile manner, so it's not going to be a steady level over the course of the day. Certain times of day, of course, the secretion is much higher than others. What TSH does is induces the expression of a sodium iodide transporter. Iodide is a cation that stored in the body, and it's acquired through the diet. Talk a little bit about that. Also, thyroglobulin and thyroperoxidase. These are important. Thyroglobulin is a binding enzyme. Thyroperoxidase is thyroglobulin is a binding protein. Thyroperoxidase is an enzyme. All involved, of course, in thyroid homeostasis. Thyroid hormone itself will act on the pituitary to cause kind of a negative feedback. And that's kind of how things are supposed to function when you have a functioning hypothalamic pituitary thyroid axis. Okay. As for the thyroid hormone itself, it consists of 2 different products, T3 and T4. T3 accounts for about 20% of the secretion from the thyroid gland, but it's a much more potent version. Triiodothyronine is about 5 times more potent. And then T4 is what we normally measure in the body. It's when we are doing thyroid assays. It accounts for about 80% of the thyroid gland secretion. And it is the product that we use most commonly in pharmaceuticals. This is just a graphic of the hypothalamic pituitary thyroid axis. From the hypothalamus, you have thyrotropin releasing hormone, and then pituitary signals using TSH, the thyroid stimulating. T4 and T3 goes into the circulation, but then also feeds back to the pituitary. Along the way, there are a couple of things that inhibit various steps of the process. Somatostatin, we kind of talked about this last week. Again, somatostatin, think of this as kind of a broad anti-secretory hormone. So it's involved in signaling in lots of different places in the body just to suppress endocrine secretion. Dopamine, glucocorticoids, and retinoids also act on the pituitary to prevent TSH secretion. And then elevated iodine tends to block thyroid hormone secretion from thyroid. So again, iodine is a ion that's obtained from the diet. For example, iodized salt contains, of course, iodide. The recommended intake is about 150 mics per day. Dietary thyroid is transported to the thyroid follicle. Thyroid, of course, is where iodide tends to concentrate in the body. Attaches to thyroglobulin. That is called organification when the dietary iodide attaches to the protein. Then you also have thyroperoxidase. So basically, thyroid hormone, kind of in its simplest explanation, I guess, basically takes tyrosine, which is an amino acid that makes up the thyroglobulin, and adds iodide to it. And that's really what thyroid hormone is. So thyroid peroxidase helps that process. Once the hormone is synthesized, there are proteins binding globulin, pre-albumin that transport the hormone to its target organs. So we'll talk about total T4 versus free T4. Free T4 really represents just a tiny amount that circulates freely in the circulation. Most of the thyroid hormone is actually bound to one of these proteins, globulin and pre-albumin. And then we said that T4 is, the predominant hormone that's secreted. T3 is the more active form. There is a deiodinase enzyme that converts T4 back to T3 and birth tissues. So where again it's activated in birth. So a little bit of this is represented here, as well as with some of the pharmacologic targets. Iodide, again, from the diet into the circulation, goes, concentrates into the thyroid cell. Organifies, meaning it adds to the tyrosine residue of the thyroglobulin. Okay, so you have these iodides that's added to this hormone, to this protein here. This is T4. T4 has four iodide atoms, and T3 has 3 iodide atoms. So basically, this is a representation of T4 bound to the peroxide. There are various processes where, again, pharmacologic targets can either inhibit the iodination or coupling, where you have these two tyrosine residues binding together. We'll talk about these drugs, pivadol and propionuracil. And then there is another pharmacologic target with supertherapeutic iodide that would prevent the release of this hormone. So that's what this negative side here represents. So what are we doing when we are managing thyroid disorders? Of course, it depends on which thyroid disorder you're dealing with. Hypothyroidism is characterized by low levels of circulating T4 on a lab assay that will often correlate with elevated levels of TSH, thyroid stimulating hormone. And I think you've covered this, you kind of know what the picture is clinically of hypothyroidism. Think of it as just kind of a depressed overall metabolism, impaired growth, intellectual development, especially when you have low fetal thyroid and early thyroid. Also decreased physiologic metabolic activity. So these patients will look tired and fatigued, mental slowing, cold intolerance, weight gain. Goiter is a kind of an adaptation to help the thyroid kind of compensate for their low output. Cardiac wise, you'll see bradycardia and an overall low cardiac output. Hypothyroidism can be caused by autoimmune disease. It can be caused by thyroid surgery, pituitary or hypothalamic dysfunction, which further upstream. And then there are certain medications such as lithium and iodine. Noticed in the previous slide, lithium is another drug that blocks the release of peroxide. So that is why lithium is indicated as a cause. And really, almost as simple as it gets for managing hypothyroidism, we have pharmacologic preparations that basically replace the missing thyroid hormone. There is the most commonly used product, which is a synthetic form of uh, thyroid hormone, which is levothyroxine. Levothyroxine basically is T4. It's branded as Synthroid, branded as Suboxone, but you'll also find generics for it. And it's available as oral and injectable. Much less commonly, though, you can find T3, branded as Cytomel, also available orally in IV. And then we have a couple of products that are kind of combinations of T4 and T3. One is a synthetic product called Liatrix, which has T3 and T4 in a 1:4 ratio. And then a natural product, Pharm thyroid, which is literally the thyroid hormone taken from, I want to say, pigs, desiccated, then prepared as a pharmacological product. And again, of course, that will contain a mix of T3 and T4. So we'll discuss each of those in turn, starting with levothyroxine, Synthroid. Definitely one of the top drugs that you'll end up encountering. It is a drug of choice for hypothyroidism. Has lots of advantages, some of which is that it gives you a fairly consistent potency compared to T3 products for the on the thyroid. And when you deal with Synthroid or its generics, one of the kind of takeaways is that to the extent possible, as providers, you want to ensure that your patients are kind of consistently using the same product. Obviously, treatment adherence and all the other considerations are important as well, but going from one generic to another generic for a drug such as this, which is considered a narrow therapeutic index drug, can lead to significant variations in thyroid levels. So you have that, but generally speaking, if you do have a patient that consistently takes their medication at the same time every day, uses the same product, you have a very predictable response. Typically speaking, we're using oral. You might have a situation, you have someone who's hospitalized, either for kind of an acute crisis of hypothyroidism, or they're unable to take PO for a prolonged period of time. So there is an IV formulation you can use in short term. But generally speaking, give it orally every day. Its absorption is best optimized when they take it on an empty stomach. Most institutional settings, you'll see them give it like an hour before breakfast, first thing in the morning, 6 a.m., 7 a.m. They have it to get the optimal absorption. But really the important thing is consistency with this. So when patients are taking it at home, they take the same amount under the same food fast conditions. But once you're at steady state, you have a long half-life, and any single skip dose is not going to really be a big deal. There are some absorption interactions that can be bound by iron, calcium, aluminum sulfate, which, if you remember, is a drug we use for stomach ulcers, as well as micro acid suppression. That's your polystyrene. It can be cleared by P450 inducers, including rifampin and carbamazepine. And then amiodarone. Amiodarone is just a very funny drug when it comes to thyroid disorders. Amiodarone has, if you know it chemically, has two iodine atoms. You can kind of see the iodine in the generic name of amiodarone. So it really has lots of unpredictable effects when it comes to causing thyroid disorders itself and then interacting with levothyroxine. So there is a wide range of doses for the oral levothyroxine tablets. The branded items look pretty much just like this. And the generics are going to, kind of come as pills in their own shapes, but will follow the same color scheme for what it's worth to you. So patients will kind of get into a comfort level with the product that they're getting. If they're on 75 micrograms of levothyroxine, they get it filled with Synthroid, or if they get it filled with the generic, it will be the same color, okay? But you think back to way when we talked about the beginning of the year, generics typically are allowed to have a 10% variation in terms of their Tmax and AUC. These are absorption parameters in terms of their pharmacokinetics. And you can have an originator drug that has certain parameters, and the generics can be within 10% of that. For narrow therapeutic index drugs such as levothyroxine, and which means there's a small window between therapeutic effects and toxic effects, the FDA tightens that to a 5% variation, right? But if you have one generic that's kind of at one end of that 5% plus 5, and another generic that's kind of at -5, you end up having kind of a 10% variation anyway when you switch from one to another. So with that being said, you really want to make sure patients, to the extent possible, again, and it's really more of a pharmacy mandate than a provider mandate, but to make sure that patients stay on the same consistent dosage. Let's see, all these other points I kind of made, and then the TSH monitoring. Okay. Again, in your clinical coursework, I'm sure you'll cover this a little bit more. But basically, the main parameter we use to monitor thyroid, hypothyroidism, and then thyroid replacement therapy is TSH, thyroid stimulating hormone. That is going to be, of course, be elevated in hypothyroidism, right? Because TSH is there to pump more thyroid hormone out of the thyroid gland. So it will, in response to low thyroid, it will actually increase TSH. But the response, because of the, long half-life and time it takes to get to steady state, you want to interpret that at around 6 to 8 weeks following consistent dosing with your thyroid replacement. So just to give you an idea of the time frame, what to look out for. That is going to account for 95% of hypothyroidism treatment. I cover the other drugs for completeness, but really Synthroid levothyroxine is pretty much the only game in town. Liothyronine cytomel is basically a T3 product, requires more frequent dosing, so shorter half-life compared to levothyroxine, has more side effects, particularly cardiac, and can be more difficult to monitor because it's a T3 product, doesn't increase T4, and T4 is the more predominant circulatory product that we are more familiar with monitoring and correlates better to patient response. But it's the more active form, so it will provide a quicker onset of action. There is both a PO and an IV version. The liothyronine actually has a better oral bioavailability than levothyroxine. It's not as mass produced. The economy of scale is such that it's actually costs more, even though it's not used as much. And again, the adverse effect profile is less favorable. It has a higher incidence of tachycardia. And then there are the two T3, T4 products, one of which is made in a lab, synthetic Liatrix, and the other is made from thyroid animal sources.
For the monitoring?
Yeah.
If we're monitoring PSH with the Synthroid, will live thyroidine also cause problems with PSH levels?
The problem with T3 by itself is that it's not as physiologic to have higher levels of T3 exogenously administered. So the effect that it does have on feeding back to the pituitary is not going to be as predictable. So it's not as straightforward as monitoring TSH4, T4. With that being said, you should have some suppression of TSH when you supplement with T3. So it can be useful, but and I've only kind of had one patient that I've recommended it for, you're really looking more clinical response. You know, are they less cold tolerant, more energetic, that sort of thing. And then monitoring, of course, for the tachycardia. Those are the key things you're looking at.
When you're starting Synthroid, are you always starting at the lowest dose and then titrating up as needed, or is it kind of dependent by like how severe?
Yeah, it's not one size fits all. Really, it's more kind of based on the judgment of the provider looking at the the thyroid panel and the level of patient symptoms. I don't ask about selecting and starting specifically dosing. Some of the clinical coursework may get into that, but it's not one of those things where everybody starts on 25 and you kind of gradually work your way up. It's going to be more in terms of what the patient decides. So here are one other thing about the Pharm thyroid, the supply of this can kind of come and go. Most of patients I see on this are, they've been on thyroid medicine for years and years and years. For whatever reason, they kind of just stay on the thyroid. But from a supply standpoint, you'll see very often these can wax and wane because of its unique production process. So that's the other issue. Variable stability, purity, potency, and I would also say availability. So this table summarizes the thyroid replacement products. And really, that's everything in a nutshell. Hypothyroidism, an opposite situation where you have elevated T4, and as a result, low TSH. The clinical picture looks the opposite. Hyperactivity of organ systems, increased metabolism. Patients will look nervous and jittery, have insomnia, weight loss, heat intolerance and flushing, cardiac output increases, and it can also be menstrual irregularities. Causes for hyperthyroidism includes Graves' disease, where there's an antibody formation against the TSH receptor. So you have less of that feedback inhibition. Inflammatory thyroid disease and drugs. Again, amiodarone appears on the list because it's the treatments are thioamide drugs, thiurosal and fluconazole. You can also give iodide, radioactive iodine, and beta blockers. Starting with thioamides, that includes two products, We use very rarely, but they're out there. SSKI is saturated solution of potassium iodide and Lugol solution. These are just pharmaceutical formulations where you have, excuse me, I'm reading from the wall. Starting with thiamide, these are the methimazole and propyluracil. That's what we're talking about. Okay, so those agents are thyroid peroxidase inhibitors. Thyroid peroxidase, you'll recall, is part of the process that leads to production of thyroid hormone. Propyluracil of the two also has an effect on inhibiting T4 to T3 conversion. So propyluracil does that in addition to inhibiting thyroid peroxidase. What these drugs don't do is affect any existing thyroid stores that are in the body. So even with consistent dosing, you're not going to see any benefit from thiamide therapy until your existing thyroid hormone stores are depleted. Methimazole has a longer half-life and less toxicity, and we use that a little bit more often. These agents are well absorbed, they concentrate in the thyroid gland where you want it to work, and they cause a rash, agranulocytosis, arthralgia, and the PTU causes more liver injury, which is why we use methimazole. So here is one approach where we are inhibiting thyroid synthesis. The iodides, the saturated solution, potassium iodide, Lugol solution, they separately will work by inhibiting thyroid hormone release. And again, I want to refer you back to this diagram. So again, two different steps, one of which is the iodination, where you're adding the iodide to the precursors, coupling T4 to T3 conversion. All of that is the thiolipids. What the iodides will do will then separately inhibit the release. Existing thyroid stores are not going to be affected by these drugs, but what the iodides will do is basically block those existing thyroid stores from being released, which is why they have a role, at least in the short term, to help patients with hyperthyroidism get over that initial period where we're not going to see any improvement with it's all a picture here. So SSKI or Lugols, we will initiate it after thiamides, can shrink the thyroid gland and will block the release of thyroid hormone. We're giving super therapeutic amounts of iodine, so you can get rash, swollen glands, ulcerations of the mucous membranes. And iodides can also protect thyroid from radioactive iodine. So if you're in some situation where you're exposed to radioactive iodine, if you blast the body with normal iodine, you can prevent that radioactive iodine from being taken into the body. But there is a role for radioactive iodine, at least kind of in a controlled clinical manner, for hyperthyroidism. The one we use therapeutically is I-131, which is different from the naturally occurring isotope of I-127. So the radioactive iodine is a heavier version. which emits gamma and beta particles. Again, iodine in whatever form isotope you give is going to concentrate in the thyroid gland. So this is an example of a radiotherapy that's really quite safe. It does not affect, say, the genital organs that can, of course, cause reproductive toxicity or, any of the other parts where you can get mutagenic effects. Radioactive iodine is pretty consistent in terms of where it concentrates. Those gamma and beta particles will basically destroy thyroid tissue fairly selectively. And over, with short-term treatment, we will see a reduction in hypothyroidism over 2 to 3 months. Now, what can then happen is the opposite, of course, is as those thyroid cells die, the patient will begin to clinically develop hypothyroidism. And in that situation, of course, the months in for lifelong therapy. There is a role for another isotope, I-123. That's more of a diagnostic tool for thyroid scans. And then finally, beta blockers. What do beta blockers do in hyperthyroidism? Well, they don't affect any of the synthetic process or secretion release of thyroid hormone, but what they do is control the patient's adrenergic response. Obviously, with hyperthyroidism, you have elevated heart rate, you have jitteriness, and the beta blockers certainly offset the adrenergic response. So it's really more just for symptomatic control, short-term, while some of these other interventions, either the radiotherapy, surgery, or pharmacologic therapies are place. That is often, you often use propranolol, about 240 milligrams a day. All right, that's thyroid for you. Question. All right, next we'll move into adrenal hormones. The adrenal hormones are steroid hormones. And basically, when we talk about steroids, we have cortisol, which is a glucocorticoid that's secreted from the zona vesiculata of the adrenals, which is here in the middle. Cortisol, glucocorticoid. You have aldosterone, which is your main mineralocorticoid. And that's secreted from your green cells. And I don't know if they're really green, but in this diagram you got. That's your mineralocorticoid. It's aldosterone. And then DHEA, which is a precursor for androgens that's secreted from the zona reticularis, this blue cells here. So this is what healthy tissue looks like. The axis here is the hypothalamus pituitary adrenal axis. So if there are pituitary effects that cause these, or pituitary effects can cause these areas to get atrophy or hypertrophy. So we'll spend most of the rest of today talking about steroids. Steroids, you should know by now, this has never been a chemistry class, but I've always kind of point out that you have this kind of very characteristic 4-ring backbone based on that cholesterol steroid structure. Cholesterol you can get from the diet. And we talked about all the different ways and what's processed by the liver, and store is HDL and LDL and all that other stuff. But cholesterol, of course, is an important backbone for all of the steroid hormones. P450 enzymes throughout this process are going to be involved in the various conversion steps. But here I have 3 pathways that are being described. You have your aldosterone pathway here. The cortisol pathway, which is here. And then the androgen pathway, which is this way. But it all comes from the same common precursor. And cholesterol basically is came from the diet and it's stored in the liver as esters. So we'll start with the hypothalamus corticotropin, or ACTH. It regulates glucocorticoid secretion. Glucocorticoids are, again, a class of drugs we really talked about all year. But it's important in just everyday homeostasis, and then has kind of times where under stress or under some sort of immune stimulation, we'll see peaks in its release. So glucocorticoids follow a diurnal rhythm. You always have a little bit going, but you do have a peak release at around 8 a.m. Adrenal corticosteroids will feed back to reduce the production of glucocorticoids. And in times of stress, you will have a dramatic response, increase of glucocorticoid secretion. So cortisol, and I'm sure you've heard it before, it is kind of your stress hormone. Think of it that way. Corticotropin, though, doesn't really have much of a use. Whenever we are trying to deal in situations where we need more glucocorticoid activity, yes, in theory, by increasing the hypothalamic signaling to the adrenals, and those downstream effects, you can, in theory, increase that. But really what we therapeutically do is just give analogs of cortisol. But corticotropin, there is a product called cosintropin, which basically takes a part of ACTH, amino acid residues 1 through 24, and isolates that as a pharmaceutical product. What it will be useful for is for determining the integrity of the HPA axis. If you give cosintropin, the expectation is after about 45 to 60 minutes of IV administration, you will see an increase in plasma cortisol. So really, this is a diagnostic to see whether the adrenals are working in that patient. If you don't see, it's called a cosintropin test. If you don't see the cortisol levels peak after about an hour after giving this, then you can conclude that the hypocortisolism is from the adrenals. All right, as for corticosteroids themselves, again, these are just widely active hormones involved in lots of different functions. But they're steroid hormones. The one thing steroid hormones have in common, other than the fact that they're all derived from cholesterol, is that they activate intracellular receptors, meaning they will bind to a receptor at the surface of the protein, and then once they're bound, it moves into the cell and activates certain genes on the DNA. So there are nuclear receptors that will then kind of code or increase the production of certain protein as a result. So there's a glucocorticoid receptor and a mineralocorticoid receptor. Cortisol is your main glucocorticoid. Pharmaceutically, the product is called hydrocortisone. But whenever we give hydrocortisone, basically we're giving the exact analog of cortisol. Secreted daily over the course of the day and circadian rhythm and responds to stress at different amounts that gets secreted. From the mineralocorticoid side is aldosterone. Aldosterone is your main mineralocorticoid, and it is secreted on a constant basis, tiny amount, 0.125 milligrams per day. And the mineralocorticoid's role is for maintaining water balance and blood pressure. Basically works at the level of kidneys for sodium absorption. Corticosteroids affect carbohydrate, protein, and lipid metabolism. Specifically, the mineralocorticoids maintain fluid and electrolyte balance. Cortisol is involved in cardiovascular, immune function, nervous system function, endocrine functions, kidneys, skeletal muscles. It's a stress hormone, so it promotes resistance to stressful stimuli, from infection to trauma to temperature extremes. And these are thought to be kind of permissive effects, meaning that cortisol can act on growth hormone. Cortisol can act on epinephrine to help in its regulatory functions. So again, very broad-based effects. CNS, excess corticosteroids can cause mood elevations, mania, insomnia, psychosis. Likewise, deficiencies can cause apathy, depression. It also cause psychosis and irritability. Fluid electrolyte side, again, most of this is regulated by aldosterone. You can get hypertension, fluid expansion. Aldosterone again tends to make you hold on to sodium and fluids. Whereas deficiency of hypoaldosteronism cause sodium wasting, decreased fluid volume, hyperkalemia, and acidosis. The skeletal muscle corticosteroids can, in excess, cause myopathy, weakness, and fatigue, and likewise in deficiency can cause limited muscle function. You also know that corticosteroids can tend to bump the white blood cells in particular, and also affect some of the other cell lines, but deficient corticosteroids can lead to anemia and psychosis as well. The corticosteroid alterations that are relevant are Addison's disease, where you have chronic insufficiency of the adrenal glands, and Cushing's syndrome, where you have excess adrenal steroid production. So Addison's, you have presents with weakness, fatigue, weight loss, and hypertension. Because of the adrenal insufficiency, you have problems maintaining glucose levels. And the thing with Addison's is that even chronically they can function, but obviously it's not optimal. Any situation where your body is normally able to produce a stress response. Okay, when you need a little bit more cortisol, because your adrenals are unable to respond to stress, any minor event can then lead to acute adrenal insufficiency, which can be life-threatening. The other cause of adrenal insufficiency is discontinuation of exogenous steroids. When you give a patient corticosteroids over a long period of time, you will actually cause your adrenals to shut down, to at least, relatively speaking, decrease their output. That's kind of a normal finding because of how steroids feed back to the adrenals. But it becomes a problem when, again, after a long period of continuous use, stopping that steroid will now mean that it takes time, even though the adrenals themselves are capable of responding, it just takes time to get back to that. So you can see adrenal suppression from long-term steroid use, which becomes acute when the steroid use is abruptly stopped. And what we do with that, of course, is to taper the dose so that the body can get used to declining levels of exogenous steroids. From the other side, Cushing's from excess adrenal steroids leads to fat deposits, muscle wasting, lipoma, cataracts, hirsutism. Too much glucocorticoid, of course, can lead to increased blood sugar and diabetes. And there are CNS effects as well, anxiety, depression, psychosis. Pharmacologically, these are systemic corticosteroids. We talked about a lot of other steroids in the asthma unit, in the dermatology unit. Of course, those are more topical, local administered agents. These systemic agents are given either orally or IV, and obviously act throughout the entire body. How these drugs are different from each other is in terms of what we call their glucocorticoid property, which is represented in the second column here, and their mineralocorticoid property, which is this column. What's going to stand out to you right away is that fludrocortisone is by far the most potent mineralocorticoid that there is. And then all of the other agents really are much more potently glucocorticoid in terms of their profile, meaning that they're either balanced, like hydrocortisone and cortisone, or they're much more predominant in terms of their glucocorticoid effects relative to their mineralocorticoid effects. Recall that hydrocortisone is basically physiologic cortisol. Cortisone is a product that's basically just a prodrug of hydrocortisone. And then as you go down the bottom half of the table, you get into more potent anti-inflammatories. So prednisone, methylprednisolone, triamcinolone, which you can give as a IM, betamethasone, and dexamethasone, as potent agents. So when you administer corticosteroids at super physiologic levels, you begin to kind of look a lot like, at least in the short term, the Cushing's type picture. Fat redistribution, the hyperglycemia, can see psychiatric changes. Cause peptic ulcers because of how they interact with your body's defenses against H. pylori. And and also increase susceptibility to systemic infections. When you withdraw from long-term use of corticosteroids, again, the underlying disease can clear up, and you get acute adrenal insufficiency. Usually, the level of corticosteroid use is about 20 milligrams a day of prednisone for about 2 to 4 weeks. But if you have a more potent steroid, you can see that insufficiency take place over a shorter period of time. When I said, sorry, more potent or a higher dose of steroids can produce that effect over a shorter period. Again, the slow taper is but on the other hand, if you need to give a high dose steroid for a much shorter period of time, or even a single dose, these are fairly well tolerated drugs. Maybe your glucose spikes a little bit in the short term, but nothing really crazy. Some of the uses, an acute adrenal insufficiency, you want to give a IV hydrocortisone bolus. Then a continuous infusion. There's a product called Cortef, which is basically the IV hydrocortisone that will help kind of replace the deficient cortisol. In chronic adrenal insufficiency, basically you need to have the patient take a daily dose of both hydrocortisone for its mineral, glucocorticoid activity, and glucocortisone for its mineralocorticoid activity. That is continuous. There's also something called the dexamethasone suppression test, where if you give a dose of the potent corticoid dexamethasone, you would expect to see a drop in cortisol levels. So that is another use. And then we have a whole host of inflammatory conditions where we can use corticosteroids. These are some examples. A lot of these we talked about again over the course of the year. A couple we haven't touched on yet. For allergic reactions, for example, someone gets a bee sting or hives or urticaria. There's a product called the Medrol dose pack. If you've ever seen this, basically it's a 6-day course of tapering methylprednisolone in a blister pack. So they basically start with by taking 6 pills on day 1, 5 pills on day 2, 4, 3, 2, 1. So it's a 3 to 5 or 6 days. So that's the methylprednisolone taper or the Medrol dose pack for allergies. A couple weeks ago, we talked about COVID-19, where dexamethasone can be part of your treatment of critical care patients experiencing cytokine storm. For bone mineral joints, arthritis, bursitis, you may use prednisone for those inflammatory conditions. Prednisone can also serve as an adjunct for chemotherapy-induced nausea and vomiting. We talked about the use of respiratory corticosteroids. Inhaled corticosteroids, of course, for asthma, and then for acute exacerbations, you can actually hospitalize someone with asthma for wheezing. You can give IV steroids and then discharge them on methylprednisolone taper. And then for spinal cord compression and other types of trauma, you will often see high doses of methylprednisolone to help protect the spinal cord trauma. So all sorts of different paradigms and uses for corticosteroids. On the other side of hypercortisolism, you have some limited options here. You could either, if in case of a sometimes we have these tumors that will secrete, ACTH or CRH. Surgical excision of those tumors would be the treatment of choice. But there are, a couple of, pharmacologic options, one of which is to target the secretion of ACTH. The other, is to block the steroidogenesis and the adrenal gland. Touching these very quickly, we probably will infrequently use these. Seriatide is a somatostatin analog, and somatostatin inhibits secretion. So you will see, a reduction in ACTH secretion. But again, somatostatin is so broad is that it will also inhibit growth of hormone with lots of other hormone secretions. So this is given subcutaneously. It will reduce free cortisol by about 50%. Pregabalin is a dopamine agonist for hypoprolactinemia. We can discuss it at the end of the lecture today, but it can also inhibit ACTH secretion. And then steroidogenesis, again, 450 enzymes are involved in multiple steps in the synthesis of steroids. One of the antifungal drugs, ketoconazole, it works in fungal cells by inhibiting fungal P450 enzymes involved in its cell wall production. So in humans, you'll have analogous effects in terms of P450 inhibition. It will inhibit steroid hormone biosynthesis. And there's another agent, tyrosine, that has a similar effect. Then we have the aldosterone antagonists, and this slide is a straight rip copy paste from when we discussed diuretics last semester. The aldosterone antagonists, these are drugs that basically oppose the effects of aldosterone. They include spironolactone and eplerenone. They basically oppose the effects of mineralocorticoid hormones. So basically, they will look a lot like the mineralocorticoid. It will bind to the receptor, but it does not locate to the nucleus. That important second step for mineralocorticoid signaling. So in situations where you have high aldosterone, these drugs will prevent the salt reabsorption, leading to more fluid output, have a mild diuretic effect, and less salt retention. So that makes it a great option for congestive heart failure patients and those with primary aldosterone. So that's your glucocorticoids and mineralocorticoids. Next are the androgens. Androgens, that's basically testosterone and dihydrotestosterone. Don't worry, ladies, we got you covered. We have a whole lot of content around estrogens and reproductive. But today is testosterone. Testosterone is the most important androgen, named in the testes, about 8 milligrams each day. The precursor is DHEA. It is converted to androstenedione and then converted to testosterone. Testosterone is further metabolized to dihydrotestosterone by 5-alpha reductase. 5-alpha reductase is a target of the 5-alpha reductase inhibitors, which is a class of drugs we talked about as well. There's a lot of nostalgia in this lecture. Stuff that in this year, it's kind of all coming together. And then the conversion of testosterone to estradiol by aromatase. Aromatase, of course, takes one of those 4 rings and aromatizes it, makes it testosterone, or it basically converts androgens to estrogens. The aromatase inhibitors, of course, is a group of drugs we talked about in breast cancer. estrogen sensitive tumors basically can see a decrease in their feeding aromatase inhibitors. Yeah, more installed. It is metabolized by the liver and binds, of course, through intracellular androgen receptors that affect gene transcription, just like with any other steroid. So with androgens, you have lots of different pharmaceutical preparations. Again, the naturally occurring products themselves is testosterone and dihydrotestosterone. You can find pharmaceutical preparations of straight testosterone as topical gels like androgel, patches such as testoderm, and then there's something called testapel, which are little pellets that can be injected. Dihydrotestosterone, there are some pharmaceutical products, but none of which are really available in the US. Esterified products basically takes a testosterone and then adds a long chain to it so that it will have a longer duration of action. Okay. Depot testosterone is testosterone cypionate or testosterone undecanoate. Okay, so these are kind of long-acting formulations you can give for those with chronic hypoaldosteronism. I'm sorry, androgenism. That will, I believe in the case of depot testosterone, you give it every 4 weeks, for example. And then there are alkylated derivatives, which are basically forms of testosterone where you add side chain to the 17 position, causing, better oral bioavailability, methyl testosterone, fluoxymesterone, oxandrolone. And then for those of you that's into sports and doping, not into it, but just familiar with some of the issues. There are all sorts of other designer androgen drugs that are used in performance enhancing. That's done for as ways to kind of detect to evade detection. Obviously, with performance enhancing drugs, it gives you a competitive advantage, and a lot of sport governing bodies test for those drugs in both men and women to make sure that there's a level playing field. But the chemist can always kind of be a step ahead by tweaking the testosterone molecule so that it still activates the receptor, but does not cause the same level of detection in the body. But what can also happen is that you get a certain level of either testosterone suppression or testosterone increase, where the person can still get caught. Well, all that to say is that you have all these different derivatives of the progenitor testosterone molecule. Okay, so these are the esters, which add this long side chain onto this hydroxy group here, and then the 17 alkylated products, which add a chain here to help with oral bioavailability. And then you have your over-the-counter products. Now, these are not testosterone-containing products, but these are the things that you hear in TV and radio commercials that appeal to guys like my age, that are experiencing less vitality and less, they don't satisfy their women as well. You hear the claims on radio and TV, and these are for products that literally are testosterone enhancers. How they work, though, if you know about pharmacology, is they contain a product called fenugreek extract. Fenugreek extract basically is not a testosterone agonist or what have you, but it does two things that tend to increase free T, or they call it serum testosterone. One is to inhibit 5-alpha reductase, 5-alpha reductase, again, prevents the conversion of testosterone to dihydrotestosterone. So it keeps that parent molecule in the system longer, but then also inhibits aromatase. And we said that aromatase converts testosterone to estrogen. So by blocking both of those pathways, we actually end up with an increase in testosterone. These products, along with hundreds of other herbals, kind of sit in this weird regulatory space. Okay, they're not marketed as drugs. They're technically food because these are things that you can get naturally and they're prepared from plants and you can brew them in teas or extract them and put them in capsules or whatever. And from a regulatory standpoint, they don't have to go to clinical trials to prove their efficacy, but they basically can't kill people. All right, that's a low bar that they have to satisfy to get onto the market. So basically, if they are safe, you can produce them and market them as long as you don't make, or let me put it this way, you keep the claims to them as vague as possible. So they make you more vital, and they make you more, more manly, I guess. I don't know. They're very kind of vague claims so that they're not saying that they can cure a particular medical issue. They're not claiming to say we can treat your hypogonadism. We're basically saying we can improve your vitality. So with that, they're able to market it, and as long as it's not killing people with some sort of percentage of arsenic that's in the plant or whatever, then they're free to market it and you can get it at the Costco or the Exxon or whatever. All right, so that's your OTC testosterone.
What?
Testosterone, and then these animal
You send it to him?
scarified agents and the alkylated agents. So physiologically, what they do during the puberty period in young boys, basically testosterone is involved in development of secondary sex characteristics, penile and scrotal growth, body hair, vocal cord thickening, and a lower pitched voice, and an increase in lean muscle mass. Decreasing protein excretion, holding on to those amino acids so that they are used to integrate into more body proteins and muscles. There are some estrogen receptor mediated effects as well. So some of the testosterone that is converted via aromatase to estrogen is important in bone growth. Okay, so that relationship between estrogen and bone will come into play when we talk about osteoporosis later this semester. And then androgens in large doses can then suppress gonadotropin secretion. So I hate to give you this image, but you have these huge bodybuilders, for example, that are on heavy doses of androgens. They will actually have testicular atrophy because basically you have all of this androgen signaling causing less reduction or less production of androgen in the testes, right? So you can get testicular atrophy. So that's kind of a feedback response. All right, so here is the hypothalamic signal, gonadotropin hormone is a leucine hormone, signals to the pituitary, which then via LH, luteinizing hormones, signals to the testes. Testes will produce testosterone, some of which is broken down to dihydrotestosterone, and some of that is aromatized via aromatase converted to estrogens. But there are various steps in this process that can be affected. And a lot of these steps are by drugs we talked about this year. Gonadotropin hormone releasing hormone agonists, for example, work way up in the hypothalamus to at least initially increase pituitary output LH, but then over time, will feedback, causing, suppression of androgen, secretion. 5-alpha reductase, can be inhibited by certain drugs, favor, testosterone in the circulation. And then we have drugs that work at the level of the androgen receptor to block, androgen signal. Therapeutic uses, basically any condition where there is insufficient testosterone, including male infertility, patients who've undergone orchidectomy, for example, with testicular cancer. They will, of course, require testosterone supplementation. Some men may benefit with osteoporosis. Again, the active moiety here is typically the estrogens. Estrogens really are the ones that is a hormone that works directly on bone, not the testosterone, but then you can give testosterone replacement for osteoporosis. Hormone replacement therapy combined with estrogens. As you can imagine, in gender affirming therapy for transgender men, part of that process is to use testosterone to masculinize some of the features. Androgens also can be used in a situation where there's failure to thrive, like weight loss in trauma patients, burn patients, end-stage age patients. And then for anti-androgens, you can utilize those agents for BPH, prostatic hypertrophy, right? Because the prostate can feed on excess testosterone. BPH, we talked about last semester, anti-androgens can shrink the prostate. Likewise, in prostate cancer and hirsutism in women, and as well as alopecia. Because alopecia is a response from excess dihydrotestosterone. Side effects may include prostate enlargement, prostate cancer, testicular atrophy, which I talked about. Gynecomastia, this is another kind of telltale sign. It's a telltale sign of blood doping in male athletes, because again, excess testosterone, certain amount of it will get converted to estrogen. It's a breast enlargement. You also see acne. There's some mineralocorticoid effects, so you get some sodium water retention. The 17-alkylated products will have some liver effects. And of course, women who take excess androgens will have masculinization. You see a more prominent jawline, boys, some of those other features. And just very quickly, anti-androgens, again, all of these we discussed at various points this year. Androgen receptor antagonists, flutamide and bicalutamide, basically, they block androgens at the level of the androgen receptor. These are short-term drugs. When we basically give the next class, we'll talk about the gonadotrophic hormone releasing hormone agonists. Basically prevents what's called a tumor flare. So, for example, leuprolide. What we want to do in prostate cancer is kind of reduce, to the extent possible, testosterone production. What we give is a GnRH analog, which will at first actually increase the production of LH, which then signals to the testes to produce more testosterone. But excess GnRH will feed back to the hypothalamus, which will then shut everything down. But in that short term where you are giving more GnRH, The androgen receptor antagonists will help with what's called a tumor flare because you get an increase in testosterone production. So that's what the first two how the first two classes of drugs are used in that list. We see spironolactone again because it has some anti-mineralocorticoid as well as androgen receptor blockade. And then finally, 5-alpha reductase inhibitors, which are finasteride and finasteride. Talked about those for BPH last semester. And in low dose form of finasteride can be helpful for male pattern baldness elevation. That's your story. Very quickly, we'll talk about hypoprolactinemia. Prolactin is a hormone that's involved in milk secretion. Prolactin is secreted by the lactotrophic cells of the pituitary gland, promotes mammary alveoli in the breast tissue to promote support milk production. Males will typically have a fairly constant low level of prolactin, but females will have varying prolactin levels based on whether they're pregnant or breastfeeding or are non-pregnant. There is some variation after meals. Hyperprolactinemia, we usually think of some sort of tumor that's causing the some sort of tumor that causes increased prolactin secretion with an adenoma or like that. Less commonly, or actually potentially more commonly, but less of a long-term issue is drug-induced prolactin elevation. Again, because prolactin and dopamine are linked, basically drugs that block dopamine and to actually increase prolactin. Briefly talk about this one. So that is just a drug-induced reversible effect. Basically, the result of elevated prolactin is galactorrhea, amenorrhea, vaginal dryness, erectile dysfunction, and fertility potentially. So what we want to do is basically give a dopamine agonist that will, again, offset the elevation of prolactin. That can include drugs such as bromocriptins and detriment. That's all I care to share about hyperprolactinemia. Right, the quick cases then, we have 33-year-old who has rheumatoid arthritis and treated with prednisone, 40 milligrams a day for flare-up. We cover rheumatoid arthritis in a lot more detail. The EMJ unit, which I think is really soon. Her dose is tapered to 20 milligrams a day after 2 weeks. But then after 2 months, she becomes uncomfortable with her increased weight and development of roundness in her face. She abruptly stops the use of the prednisone. What can happen? You abruptly stop the use of prednisone after several weeks of treatment. Next, we get an adrenal concussion, and really, if she was working with her well-trained provider, she would have been given a opportunity to taper that dose of drug. You know, tapering is more of an art than a science, but the idea is, say, 20 milligrams, prednisone comes in like 1, 5, 10 milligram doses. But the longer you're on it, the longer the taper should be. But other than that, there isn't really a great science behind it. But I would at least give, 7 to 10 days gradually declining doses so that you can have the adrenals build back up. A 69-year-old man who goes to his provider, he's been feeling fatigued and lethargic. Provider does a complete evaluation, the TSH is elevated, T4 is slightly decreased. Okay, your diagnosis is what? Fatigue, lethargy, elevated TSH.
Hypothyroidism.
That's hypothyroidism. And what is your first,
Synthroid.
okay, you go to Synthroid, levothyroxine, and, basically instruct the patient to take it on an empty stomach, consistently, same time every day. And you probably bring them back, when?
6 weeks.
About 6 weeks. And continue to follow TSH. See how he's doing clinically and, see what the objective, findings are on the thyroid panel. Make your dosage adjustments from there. And then finally, you have a 46-year-old who's diagnosed with hypogonadism, low serum testosterone. And what options are available for him? So he said that there are lots of different formulations of testosterone that's available. Administered as topicals, creams, patches. You can get oral forms of alkylated testosterone or even a esterified testosterone. And then the injectables those like severely unidentified esters. Sorry, yeah, that you agree. But that's, we'll say is your off-label usage. Any questions? So really, I said nice and tidy, we're not here.